Hello, my name is Deborah Ard, and I would like to share with you my practicum experience Culmination Project for Nursing 623. This is Mount Kanakta, an active volcano perched on the shore of Clear Lake, the largest freshwater lake in California. Due to the density of population around both, there is potential for catastrophic disaster in this county. Lake County is both volcanic and seismic. As you can see, most victims of a disaster can be treated with professional first aid. Only a small percentage require acute inpatient status. You can also see that in major disasters, most people bypass the EMS and go directly to the hospital. This rush of victims can overwhelm hospital staff and is avoidable with a disaster surge plan. In a surge plan, several alternate sites spread across a county and announced on emergency radio make it easier for victims to get the treatment that they need for their injuries. An already limited road system here that is further compromised by a disaster can mean that the alternate field site is the only option for victims any distance from the hospitals. The National Academy's Institute of Medicine recommends a plan be capable of caring for victims for up to 96 hours, as help may take that long to arrive, and transfer of patients to outside areas may not be possible. The focus of this practicum is to create a team of volunteer healthcare professionals to man alternate field sites throughout the county to receive, triage, and treat victims. The intent being to protect the two county hospitals from being overwhelmed in the event of a major disaster. This is a surge plan. The core team for creating this plan is the County Public Health Officer, Dr. Karen Tate, 2 Public Health RNs, and myself, essentially the entire staff of the County Public Health Branch. My role in all this is to recruit, educate, and support a team of healthcare professionals and ancillary staff. Also to help persuade administrators from both hospitals to buy in with staff and supplies. These are the role functions that my part will entail. First task is to get the buy-in of local hospital administrators, as the County Public Health Office has only 2 RNs, a physician, and this is not near enough personnel for a field unit, nor does the Public Health Office have funding for supplies. It has been difficult to meet with hospital administrators. We've not been able to get a time that's been satisfactory for all of them, but I am happy to report, though, that a date time has been found that Dr. Tate and the medical director of a hospital and the hospital CEO and the director of nursing and the emergency room director and myself can meet. At this meeting, I am to give a presentation of the need for the surge plan and the advantage it has for the hospitals involved in a disaster. I will also ask and hopefully get an agreement that this group become part of the core team. These are my competencies for that part of the project alone. After buy-in by the hospital, it will be up to me to do the presentations to staff to recruit volunteers to go through training. The team will be at least made up of nurses, a physician, respiratory therapist, infection control, nurses' aides, mental health, and clerical and administrative support staff. Leadership is the main focus, support and nurturing of those who will be in direct care. The education focus will be different than even the emergency staff will be accustomed to. Not only will we be triaging and initially treat, but we also may very well have patients, quote, admitted to us for extended treatment that does not need transfer to the hospital. This was one reason Dr. Tate wanted me in this role, as a medical surgical nurse's level of ongoing care would be appropriate. And yes, this will be the role of an educator. All 3 of these issues will be carrying over into the next practicum. My 5-point analysis for one of the carryover issues is the issue of surge education for the team. The focus will be to reorient the team from inpatient to disaster surge thinking, where supplies and medications may be limited, and the focus will be to do the most good for the most patients who have a chance to survive. The, quote, patients for the education issue will be actually the team volunteers. Another aim of the education will be to avoid emotional trauma to the responders if at all possible. In a disaster when resources are limited and there is no code blue, if they die, leave them and go to the next victim. This may be emotionally difficult for some team members. The education team is myself, Dr. Tate, and Linda Fraser. She is the Health Education Program Coordinator. This enormous toolkit has key components and definitions that is being modified by the education team for the responders' education. After successful recruitment of a surge team, attrition is the main concern. It has been postulated by our group that at least the initial education be self-paced and simple in order to avoid this. As responders learn and remain in the program, more in-depth information can become available to those who express a desire to learn more. Complacency will be difficult to overcome. People have lived without incident for generations, and many, including many healthcare professionals, do not see the need for a disaster surge plan.